Dear peer, good evening. As you all know, one of the important subject in the endourology is PCNL. Without PCNL, there is no endourology. Normally, in the PCNL, whether it is prone PCNL or supine PCNL, we dilate the tract to remove the stones. So, even though we are not going into the details of the nomenclature, let us learn the practical points from Dr. S.K. Pal sir, who has done pioneering work in PCNL for last 3 decades. How much we have to dilate? Sometimes we dilate 30 also to remove large stone. Sometimes we dilate up to 12 to remove small stone. But what are the advantages? What are the disadvantages when we have to dilate a larger size? Let us know from sir. Before going to the subject, I will introduce sir officially. Many of the people in India know Dr. S.K. Pal sir as mainly PCNL surgeon. S.K. Pal sir means PCNL surgeon and teacher. So today we are fortunate that this is the second or third time sir is coming back to teach us on a subspecialty of the topic. It's not like PCNL. Some time back, how the staghorn has to be dealt, how a prone PCNL puncture. In fact, the first topic in the prone PCNL puncture is the highest viewed, that is around 58,000 in the pure urology discussions. So that is the following of Dr. S.K. Pal sir for his excellent basics on puncturing of the prone PCNL. Now coming to the introduction, for those youngsters who are joining hundreds and thousands in the last 2-3 years, maybe it is useful to them. Dr. S.K. Pal sir is Senior Consultant Urologist, Apollo Hospitals, New Delhi now, Chairman, Urolithiasis Section of Urology Society of India, Vice President, International Alliance of Urolithiasis, President, Golden Bridge Urological Association. Developed a special interest in kidney diseases since 1986 and devoted his career on urolithiasis. Completed 10,000 PCNL operations for kidney stones in July 2018 and has organized 10 large international live operative workshops on PCNL every year. Even this year it is there at New Delhi, India, called PERCONS to teach this surgery to a younger generation of urologists. PERCONS are now world largest live operative workshop on PCNL, no doubt. Contributed chapter on fluoroscopy guided access for PCNL in a book on minimally invasive PCNL. Participated in live operative faculty for demonstration of various types of PCNL surgeries in 190 live operative workshops all over the globe, including China, Turkey, Doha, Iraq, Morocco, Pakistan, Philippines, and Nepal. I am fortunate to travel along with the sir to Morocco recently, 3 years back, and witnessed the amount of the following there at Morocco and Southeast East Asian countries. Has been invited to deliver talks on various aspects of PCNL in international meetings of Society of International Urology, European Association of Urology, World Congress of Endourology, Challenges in Endourology, expert in stone disease, and during annual meetings of Chinese Urology Associations. Very few Indians have done live workshops in China with PCNL and also participated in the challenges in endourology, predominantly was done in the European countries. East Asian Society of Endourology, Pakistan Association of Urologists. So with this introduction, there is no other person to learn any subject on prone PCNL, Dr. S.K. Pal sir. Over to you, sir. Thank you very much. Sir, I shared the screen. This is going. Yes, sir.
Has it come on your screen?
Sir, at the moment is in the, you have not pressed the double click the full screen, sir. On the slide, it is showing all the slides.
Is it?
Yeah. In my screen, it is showing all the slides. In your screen, it is only open, sir.
Yeah.
First click, double click, sir.
Now?
First slide. No, sir. Still it is not come. Yeah, sir. Thank you. Now we are visible,
But
sir.
is it on the full screen now?
Yes, sir. Full screen, sir, now.
Okay. Thank you, Dr. Chandra, for giving me this opportunity again. And thanks to, I think, world's largest online group of urologists, the Pure Urology group, where I have already shared 3 times my thoughts on tips and tricks of staghorn stones, on supracostal punctures, and regarding whether we should do a posterior calycial puncture or anterior calycial puncture. Is my voice and slides
Yes, sir.
clear,
Very
Dr.
clear,
Chandra?
sir. Very clear.
Okay.
Very clear, sir.
So I bring you greetings, all the viewers from Apollo Hospitals, New Delhi, where I am working. And today I will discuss about how to decide the size of the tract in PCNL. And when we talk about this, we should see the evolution of PCNL when this was taking place from 1976 to 82. In these 6 years, there were not very effective fragmentation devices were available. And therefore, we had to increase the size of the tract so as to reach to the size of the stone. And then the whole stone was removed with the help of either foreign body forceps, with the cystoscope, or through any other means. So even Hagar's dilators were being used for dilatation of the nephrostomy tract. On a daily basis, the tract size was increased till we reached to the size of the stone and the whole stone was removed. This was the first publication in the world about first 3 cases of PCNL which was published in 1976 in Scandinavian Journal of Urology. And after 6 years, when Dr. Arthur Smith and his team, they published their article in the Journal of Radiology in 1982, and their experience of 63 calculi, the average PCNL tract size was 50 French. So we should all be aware of it. And because at that time not good fragmentation devices were available, we needed a large sturdy forceps so that we hold the stone, do not lose it in the track or get impacted in between. So we needed a 10 to 12 French forceps, and that will go through a large nephroscope working channel only. Therefore, from 80 to 95 for 15 years, all commercially available nephroscopes were either of 24 or 27 French size. Now, when the nephroscope is so large, you have to have a bigger track of 26 to 32 French. And this is called standard PCNL today. Even if we were making 4 or 5 tracks, all were 30 French, minimum 26 French to use 24 French nephroscope. And even this 10 months old child, at that time I had to do with the 30 French track. So this was happening. In 1995, this idea was mooted that if we miniaturize the instrument size and the track, probably the invasiveness of the procedure will also reduce. And then this started appearing in literature. In 97, Halal used pediatric cystoscope and 15 French peel-away sheath, and he could remove stone from a child 2 years old. In 1998, Jackman published this publication, and he used a cystoscope, same pediatric cystoscope, and 9.8 French flexible ureteroscope. So like that, the size was reducing and interest was increasing. And now this was in the year 2000 when Monga and Ogilvy, they published on mini PCNL. So this is how the thought process was going on, and gradually now we have better instruments. These started getting available from the year 2000 onwards. Now the nephroscope available are from 8 French to 27 French. Optics is better, light source is better, cameras are excellent, beautiful stone fragmentation devices have arrived, and irrigation systems have also improved. So with all this, the time has come when all these miniaturized techniques of PCNL are flourishing. The mini PCNL was started in China. Minimally invasive PCNL started in Germany by Odo Nagale, and micro PCNL again started in Germany. Ultra mini PCNL, our Janak Bhai, he started using a 11 French track, and super mini PCNL with suction was started with Zheng in China once again. So now is the time when we should think, is miniaturization better? And for that, what issues we should consider? We should see about the renal parenchymal injury. We should study about the blood loss. We should study about the stone clearance rates, impact of fragmentation, and regarding rise of intrapelvic pressure and resultant sepsis. If all these points are better for the miniaturized techniques, definitely we should adopt that, and let us study them one by one. Regarding volume of renal parenchymal injury, the scar, amount of renal parenchymal loss, very few studies are available, and this study is being quoted again and again, where in the same pig, 11 French versus 30 French tracks were made, and when the renal parenchymal scar was studied, there was no statistically significant difference in renal scar volume. There are other studies also in the same way. They also mentioned the scar remains the same, whether the tract size is 11 or it is 30. Regarding blood loss, this is the main point. All studies, they have definitely proved without doubt that if there is a smaller size, the blood loss is less. This large study of 5,214 patients also definitely confirmed that when the stone size, when the tract size is between 18 French and below, the blood transfusion rate is all 1.1%. When it becomes 27, 28, and 30, there is a blood transfusion rate of almost 6%. So 5 times or 6 times increase in the blood loss if you are having a bigger size. This is now established beyond any doubt. Regarding stone clearance, which is better, many direct head-to-head comparisons have taken place, and almost all publications where direct competitions have taken place in the hands of the same surgeons, they have shown there is no difference in the stone clearance rate, whether you use a mini PCNL or you use a standard PCNL. There is always a equal stone clearance rate. Regarding impact of fragmentation, this is the point which we should understand. If the tract size is smaller, there is more fragmentation required. And then when there are more fragments, the time taken in surgery will also increase. This is a very logical understanding. Now, as such, this paper had appeared way back in Brazilian Journal of Urology in 2000, and which had really made me think about this. When there is a single stone is taken out in toto, in comparison to when there is a fragmentation of the same stone, either by ESWL or by any other means, then the potential for leaving residual stones is greater when you fragment the stone. This study was really eye-opener. All full stone was removed, whether it was by ESWL or by PCNL. And after 1 year, when the same patients were studied again, after ESWL, the new stone formation or recurrence of the stone was 22.2% within a year on the patients who had undergone ESWL, as compared to 4.2% who had undergone PCNL. So if you try to understand the fragmentation, you just think that the stone is not a straight chip. It is a cube. It has all the 3 dimensions. If we consider a 1 centimeter stone with 10 into 10 into 10 millimeter size, it will have 125 fragments of 2 into 2 into 2, not only 5. Similarly, if the stones, any 21 millimeter stone, which is now usual stone which we take up for PCNL or bigger, If you take out 7 millimeter fragments of this, there will be only 27 fragments. But if you fragment it to 3 millimeter, there will be 343 fragments. And if you try to powder it to 1 millimeter fragment, there will be 9,261 fragments of this. So there is a huge stone burden. To think about practically, if you have a 24 French sheath which has a 8 millimeter internal diameter, from where you can remove a stone of 7 millimeter, in a 24 French sheath, you will be removing only 27 fragments. But if you reduce the size to half, from 24 to 12 French, from where you can remove the fragments of 3 into 3 into 3, you have to remove almost 13 times more number of fragments. It is not just double the number of fragments. So fragmentation increases the burden of removal of more number of particles in leading to enormous increasing in operating time. Similarly, there is a formation of stone dust if you fragment, which may migrate to inaccessible calyces with turbulent flow of irrigation fluid, which is an integral part of many miniaturized techniques. And there is a higher probability of these fragments moving and remaining behind, and they will cause recurrence. And we know there is abundant literature available. If there are residual fragments, what happens? All Almost 30% of the residual fragments are infected, and they will continue to cause recurrent UTI. Even uninfected residual fragments, they come out in about next 24 months. 40% of the individuals, they will develop some symptom or the other, and you will have to remove these stone fragments. Residual stone fragments provide increased surface area for stone growth and act as nidus, which causes new stone formation in the lithogenic environment of a stone former patient. And way back when this term was coined, insignificant residual fragments to give excuse to the ESWL, at that time it was considered as insignificant residual stone fragments, but now this term has received widespread criticism in the literature. So all these points must be considered, and higher recurrence rates may be caused by microscopic sand particles migrating to dependent calyces and acting as nidus for new stone formation. So this thing should remain in your mind when you are trying to reduce the size of your tract. The last point which we should consider about when we are going to reduce the tract size is about generation of high intrapelvic pressures and incidence of septic complications. We know even as low as 40 centimeter of water pressure, the pilovenous backflow starts. And when the pressure goes to 60 to 80 centimeter, the fornicial rupture can take place. And if there is smallest amount of infection within the stone, or if the urine is infected, there is a chance of septic complication. This was studied by this paper regarding the pelvic pressures, and they placed during mini PCNL four types of PCNL they did and studied the pressure. 14 French sheaths, 16 French sheaths, 18 French sheaths, and in the last case, they had placed two 16 French sheaths. From one, the fluid was going in, and from the other, the fluid was going out, draining out. So in this way, the intrapelvic pressure was drastically reduced from 24 millimeter of mercury to 5.8 millimeters of mercury. So certainly, when there is a smaller employed sheath, the intrapelvic pressure is more. And when there is a good drainage available, the intrapelvic pressure goes down. However, in their study, they accepted that there is a rise of intrapelvic pressure with the smaller sheaths, but septic complications and extravasation were not statistically significant according to their study. So with this, now we have understood that miniaturized techniques are better because of less bleeding complications. Miniaturized techniques have no difference when there is a similar or apparent stone clearance rates and there is a similar nephron loss. And they are of doubtful status because of possibility of higher recurrence rates and possibility of higher septic complications. So when you are trying to reduce the size, you have to consider all these factors very well and then decide. So in this context, which technique of PCNL should be the gold standard? In present situation, middle path appears to be the best. PCNL tract should not be too small that you cannot remove the stone particles. That we have to dust the stone with laser only. When you are doing PCNL, why don't you take the advantage of giving more clearance and not dusting? Free irrigation it should not be too small that free irrigation is not possible and pressure will rise. But at the same time, when the good instruments are available, good optics is available, PCNL trick should not be too big that it causes significant bleeding complications. And in this, at the same time, remember, although larger tracts allowed, better irrigation and clear vision in spite of using grasping forceps, because when you pass the grasping forceps through your nephroscope, the irrigation stops or reduces. So there is no rise of intrapelvic pressure when they are using a large tract. There is no need of dusting, and there is a quick removal of good number of fragments. So these all points must be considered, and according to me, 14 to 26 French tract size appears to be ideal, and with appropriate but smaller nephroscope, whichever you possess. With this basic understanding and experience of our seniors, choosing the best tract size largely depends upon point number one, which you should consider how much stone bulk you are going to remove and what is the location of that stone bulk in the pelvic ileal system. What is the size of nephroscope available with you? What is the width of the infundibulum through which you are passing? Because you are going to make a track in the calyx only and then you have to pass through the infundibulum. And what are the comorbidities? Whether a patient can tolerate more blood loss, particularly in children. So all these points you have to consider and then think what you are going to use. And here I would like to say about width of the infundibulum. All infundibuli are surrounded with the vessels. And if by mistake you make a little more deeper go out of the system, you are very likely to go inside the vessel. And you know, sometimes in the nephroscopy, you see such pulsating vessels just below. And if by mistake your tract was large and going through and through, you are going to create a lot of bleeding. So width of the infundibulum is a very, very, very important aspect before you take up the case for PCNL. You should see, study, and then decide. This particular case, I wanted to remove the stone intact, and when I made a track of 18 French, 21 French, and I was using because this patient, this particular person had gone for the just a examination before he could be taken in the Delhi metro. And when they detected the stone, they gave him only 10 days time to get the stone out and come. So I wanted to remove the stone intact. And this is what happened by mistake. There was an injury just below the infundibulum. The stone was lying here, and this was the injury. This was the infundibulum leading towards the pelvis. This was the injury. You go closer to the injury. When you see the injury during dilatation of the tract, when you go inside, this is what was seen. And this was a direct entry into the segmental vein, which is just outside the below the infundibulum, the area which I showed in the previous slide. I could go inside this with the 12 French nephroscope. I visited up to inferior vena cava and came back. So all this is possible. Remember, infundibulum is surrounded by the vessels all around. Respect infundibulum. Don't tear or injure the infundibulum. Don't do phleboscopy during PCN. So with all this, because I have all the four nephroscopes with me, so I do these four types of PCNL. Mostly about 40% of my cases are big stones. So I will be using 22 to 24 French implant sheets with 19 French nephroscope. This is most commonly for staghorns. 30% of stones I will do with this. About 10% will be too huge, like this particular stone which I did recently. This is all plain X-ray KUB. So first for draining the pus in this nephrostomy was done, and later on all the stone was removed, and I used a 30 French tract and a 26 French nephroscope. This is 50% of my cases are by using by 15, 18.5 or 20 French sheets. And since I have a 12 French nephroscope and as well as a 19 French nephroscope, which goes through the 21 French sheets, this is my most common combination. Even such stones which are having heterogeneous stone formation, these are easily breakable calcium oxalate dihydrate stone. There is no need to put a very big sheath in this case. A 21 French sheath and a 19 French nephroscope will do. So all is decided about the stone, the the breakability of the stone, but about 8% of cases will be done through the 14 French implant sheaths and with the 12 French nephroscope. These are very small stones, and particularly these one. You see this case where the stone is located in the pelvis and all around the infundibuli are very thin. Now, in this case, there is no need. No, we should not do a bigger than 14 French implant sheath and use a 12 French nephroscope so that you can remove. No need to injure this infundibulum. Lastly, very few cases like this I should have done through the Elkin cannula of 10 French and using 8 French nephroscope, which I have procured from Apple about 10 years ago, and it is really working very well. But only problem is with this, when I use through the Elkin cannula and this 8 French nephroscope, I cannot pick up the particles and come out. It is just like a RIRS. I fragment it well, dust it well, and leave it there with the digest. Maybe sometimes a nephrostomy can be put, but otherwise only a digest. So this is all my technique is where I am using all these 4 techniques judiciously, case to case basis. Thank you very much. I think I could elaborate when to use what and what are the advantages and what are the disadvantages. And with all this, let me take this opportunity to invite all of you to PERCON 2024. The preparations are going on well. All are cordially invited. 28th and 29th of September in New Delhi, India. And all details are available on this website, percon2024.com. Welcome all. Thank you, Chandra, for giving me this opportunity.
Thank you very much. It's not an opportunity, it is for the youngsters. Now we will take some questions because a lot of audience are there. Sir, to register for PCNL outside our country, is there any difficult process or anybody can, because this pure urology is almost Asian countries. Now it is 11,000 people are there. I know the value of the PERCON workshop. So let me have some idea that to get privately for a workshop in India, are there any hurdles or directly register and get apply for visa and come?
No, there are hurdles. There are sometimes visa problem with some countries.
Is there any country which needs your letter like that? I am asking.
Yeah, particularly Bangladesh, they respect our letters. Sri Lanka also, they respect our letters. Maybe Vietnam also.
A lot of Philippines are asking.
Many countries, I will recommend not to register online because refunding becomes a very big issue. If the person is not able to attend,
India, sir.
So they should come when they reach at the venue, then they should register. And then they are registered at the minimum cost.
Minimum cost. That is good. Second thing, sir, is a 2 days workshop.
Better to take a visitor visa. Tourist visa is the best.
Tourist
Don't
visa.
register for the conference. They should register for the tourist visa. Just tourist visa. They are going to see Taj Mahal.
Sir, what
So
are you planning for in 2 days, sir? How many, what type of surgeries you are planning? What is the gross scientific program? Of course, many people have access to your scientific program, but if you don't mind, can you briefly tell about the scientific program you are planning? Most probably you might have finished the scientific program agenda for PERCOM.
during Percon, our basic concentration is on the juniors, third
Sir,
year PGs, and who have just passed out. So
sir,
basically, we will be aiming to involve them, and therefore, out of 12 cases, minimum 8 or 9 cases will be simple cases where how to make puncture.
okay,
They should be confident about it. 3 to 4 cases will be difficult and advanced cases.
okay,
So that way, and then therefore the presentations are also covering all the sessions, right from anatomy to the complications. So we try to discuss everything. And since PCNL is a very controversial topic, there are so many controversies. So we discuss about, we will make some debates also. And supine PCNL is coming up. So we want to have a symposium on supine PCNL. So it
sir.
will be a combination of lecture, debate, symposia, live operative workshop. Basically, for the juniors, 75% oriented for the youngsters who are going to start, 25% for those who have already mastered. That is the theme.
Sir, with this, I like to have questions with my knowledge and related to the tract size. First question, sir. Any any stone which is of a reasonable size, if we puncture, people say if we have a perfect puncture, it doesn't make any difference 10 French, 20 or 30 French. Clear puncture at the periphery, clear water, take out the stone intact also with 30 French. Is it always true or sometimes things can go wrong?
PCNL is a very unpredictable surgery.
Sir,
At any point, it may go wrong. So
yes,
you should be very peaceful, calm, and quiet. You should be thorough with the patient, with the atmosphere, and then only you should start. Don't take any PCNL for granted. It may go wrong at any stage.
so
And
good
please,
puncture doesn't mean that you finished the surgery.
yes,
No.
never be a hero in PCNL.
If the good puncture, clear water means you have finished surgery, you cannot do faster and whatever the way you want, because direction of dilatation also matters sometimes, as you have shown in one picture that how a small stone when you are dealing went into vein.
At any stage, the complication may arise.
Yeah.
You have finished everything nicely, and when you are coming out and you see the colonic contents,
Yes,
so that is also possible.
it is also possible.
So you
Second
have to be
question, sir,
careful at every step.
at every step. Second
Hmm.
question, when I do with 12 French, whatever coral stage nephroscope, which is very famous, with laser, somehow I am never comfortable, sir. Lot of people say that it's wonderful whirlpool effect because I also do RIRS. I also know what is powder. When I am doing the powder and saying that it will suck out, some amount of powder settles somewhere, which is not easy to see. So you already told that it is the 18 to 22, 19 French scope and 22 to 24 is better. So in that case, which cases you will use apart from the long infundibulum, which you have shown, I understand. In your practice, for example, if you are doing 100 cases in a month, 12 French nephroscope, some people talk crazily about it, but I feel 12 French nephroscope takes a lot of time for me. I get irritated. I increase the pressure. I cannot use pneumatic very well. I am pneumatic for PCNL. Using laser larger fiber is okay, but you have to aim for fragmentation. They don't come out so easily. Forceps, if you put water, will not be seen. A small amount of blood will hamper the vision. Overall, it took 45 minutes if I have done dilatation up to 18 French with 15, oh, much. In fact, 22 by 18 is luxury. So are we still favoring 12 French nephroscope? Let it be any company.
Chandra, this statement of yours speaks volumes of your experience. Whatever you have said is absolutely correct. I agree to that. 12
Yes,
French nephroscope, although it is being sold right and left these days and everybody is talking about
yes,
it, but the vision through that and the irrigation, if you don't pass any instrument, irrigation is very good. But as soon as you pass even point 0.8 French lithoclast probe or a
pneumatic
3 or 4 French forceps,
probe.
the irrigation goes down a lot and then vision becomes very poor. It is easily accessible to all the calyces where your 19 French will not go. Your 19 French will not go below the PUJ, but your 12 French nephroscope will go everywhere. It will visit every part of the kidney. So there are definite advantages of 12 French, but if someone asks me if he can buy only one nephroscope, whether he should go for 12 or he should go for 19, I will opt for 19.
19.
Because 19 French,
Great.
if you
That's what.
have a 5.5 French this forceps, in spite of that, irrigation is good. The vision is always very clear. And at the end, I always love when the fragmentation and with the 19, if there is no infection in the system, I will give a good irrigation, watch each and every calyx, even small dust which is sitting on the mucosa. I
Sir.
don't know, I am fanatic. I will remove that also.
Yeah. Right,
So
sir.
that gives me a great satisfaction
Fine,
of
sir.
complete clearance. At times, patient just asks me whether he can go for the CT scan tomorrow. Most of the times, I am confident. Okay, go ahead.
Go ahead. Yeah.
Yes.
Sir, third
So
question. Yes.
19 is definitely better. The
19.
12 has few advantages.
Sir.
Everywhere you can visit, all parts of the kidney you can visit.
Sir, similarly, extension of the question. Are we not making fools the people who are watching by showing 3 mm versus 4 mm on the line, saying that it is cosmetic? Everybody shows, see this, see this. I always put one stitch, whatever it may be. And that one stitch is same for 9 French, 12 French, 18 French, even 30 French. It is only one silk stitch will be put on the skin. If you remove on third day, hardly you see a horizontal scar, only a vertical scar, depending on the patient collagen characteristics, the scar will be there. But I have not seen somebody saying that why you have made such a big cut in PCNL. I have never seen. I also have 20 years of experience, and no lady in any part of the dress will see that. So logically, pain and showing the small scar, apart from the logistics of infundibulum, removal of the size, does it have any sense of a smaller size tract in the nerve pain as well as the cosmetic concern?
This 3 millimeter versus 9 millimeter is just a gimmick.
Yeah,
It is
yes,
just an advertisement and feeling safe. It doesn't make any difference to the patient. Sometimes you use smaller, but by mistake, your knife makes a little bigger, more than 3, 5, 7 millimeter. Who is going to measure this? And as
no.
you rightly said, one stitch is enough.
For
Whether
any
it's a 3
stitches,
French, when you have passed a 14 French, I always try to put a stitch,
I also say.
without a stitch.
Yes, sir, yes, sir.
Because by the evening something will ooze out and the
Yeah,
patient will be at your neck that there is a bleeding from there. It may be miniaturized only, but they will be on you. So putting a stitch is always better. So
sir.
whether it is 3 millimeter or 9 millimeter, it doesn't make any
One
difference.
stitch.
So neither to the patient nor to you nor to
Sorry. So my fourth question. If you have gone into the PCS with a small nephroscope, 12 French, you felt that the stone is big. You underestimated or whatever it may be. But clearly periphery of the infundibulum, periphery of the calyx you entered. You thought that the infundibulum is narrow and all the problems, but when you went inside, it is quite distensible. Can you quickly pass a guide wire and extend the dilatation and quickly come out of the surgery by visualizing the tract after either 9 French, 10 French, 12 French, whatever the scope available. Usually 9 French does not give that idea also, I feel. 12 minimum we have to go inside. I mean to ask, visualize the calyx which you have gone and then dilate up to 20 French. If you are not a busy practitioner, this is only if you are doing one case per day or one case in a week. If a junior is doing afraid everything, can you do that, or is it a difficult process?
This happens very often because in radiological images, whether it is a CT urography or a IVU, the infundibulum may look narrow. But once you go in, you find it is very easily distensible. Then why to waste time and energy and just remain to the smaller size? This is very commonly, I don't pass a guide wire then, I pass a guide rod.
All can.
The guide rod right up to the stone.
Okay.
Then the dilator over the guide rod. There is no need of putting a guide wire now. Guide rod goes up to the stone through the infundibulum. I know now infundibulum is safe.
Good.
So then I will pass the dilator on which implant sheath was passed, remove the implant sheath, increase the size of the track, and then put a bigger implant sheath and use a bigger nephroscope. This is a very common occurrence.
Okay.
But
one
if
question
it is if the implants and if the patient is not a very small child, and if it is, then I always try to do a bigger dilatation, and a 19 French nephroscope is my choice.
Yes, sir. Sir, one question from the audience. It's a good question. Wasif Ashraf, does Hounsfield unit of the stone has anything to do with size of the tract if you don't have laser available with you? If you don't have laser available with you? It's a good question.
See, even when the laser was not available, we were breaking all stones with lithoclast. It is not that the laser is a must.
He's asking, at a hard stone require your mindset to make it a larger size tract, is asked.
Yes, because even time will be required for breaking a large stone. Time duration, because I want to limit my 80-90% of my PCNLs to within 1 hour. 10 or 20% will go beyond 1 hour, but never beyond 2 hours. So I want to limit the time of my surgery. And a lot of time is wasted in breaking a harder stone. So then I will try to make bigger stone particles and remove them. So if it is a Hounsfield unit is beyond 1200, I will opt for a bigger size of the implant sheath, so that less number of fragments and quick removal. Yes, but if the stone which I showed, if it is a heterogeneous calcification, a calcium oxalate dihydrate, which will fragment and crumple easily, even large stone, they will just crumple and they will come out. So then no need to increase the size. But harder the stone, bigger the size. This is absolutely agreed.
Sir, in PCNL, prone PCNL, if the ureteric catheter is there, some says that with multiple holes ureteric catheter is good. Some say large ureteric catheter is good. Some say you use pressure whenever required so that you get out of the fragments. Does it have any meaning, or just pick it up by you are there to pick it up, not to flush it off? Flush it off in the PCNL, not necessary, because your implant sheath is not too long like in RARS. You have a forceps, you have a baskets. So contrast installation, okay. But after the constant installation, in your experience, how much you use ureteric catheter flushing for doing the surgery in PCNL?
Ureteric catheter will just bring the fluid to the tip of the ureteric catheter. Now, when this fluid is coming inside the pelvic ileal system from the tip of ureteric catheter, whether it comes from one hole, two hole, tip or side, it doesn't make any difference. When you are injecting with little force, shower will come inside the PUJ and irrigate the whole system. So it doesn't make any difference. Tip hole or a side hole or one hole or five hole doesn't make any difference. But I always keep the ureteric catheter till the end, because at the end I will pull it down little bit, then again push saline so that some fragments which were not seen, because stone fragments less than 2 millimeter are not seen in CM. So if there's some stone fragments or some dust has gone down beyond PUJ, maybe 3 to 5 centimeter below PUJ, all those fragments they come in front of me. When at that time I am watching at the PUJ, asking the assistant to flush, and then all that area is also cleaned, sucked off, then only I am satisfied. So I keep the ureteric catheter till the end. At times there is a lot of edema, congestion, very abnormal system where identification of PUJ becomes difficult. You must have seen some cases where the
Yes.
PUJ, if there is no ureteric catheter or no
Yeah,
guide wire coming
that
in,
is the frustrating
identification
situation.
of PUJ is
Yes,
difficult.
yes.
So I don't try to remove the ureteric catheter below till I have passed a guide wire and I have passed a
Yeah, yeah.
double J stent is there. So
Okay.
as such, number, size, ureteric catheter doesn't make any.
Yes. So my sixth question, when you enter the PCS with to above 20 size French from the lower calyx, and you wanted to go to the upper calyx for a migrated stone, you feel that something is not allowing you to turn with your scope of 22 French or 22 above. If you wanted to exchange and use a smaller nephroscope, there are two problems. One is if you put smaller nephroscope, water will not retain, system collapses and everything looks bloody. Second thing, replacing amplage through amplage is a tricky job. You may lose the bus. But some people will put one amplage into another amplage, remove outside, suddenly both amplage will come out. Then disaster. So, and bleeding also happen if you change from 24 to 12 and try to negotiate there. Snugly doesn't fit the original fitting, which causes less bleeding will not be there. Something immediately parenchyma bleeds for at least 5 minutes. In that 5 minutes is precious for that. So how do you exchange the tract from larger to smaller to go one calyx to other?
Going from one calyx to other, and if the kidney is not distensible, I will put the nipple through which you are passing the instrument on the amplage sheet.
Nipple is
Over
made
the
up.
amplage sheet, it will come like a nipple. And
Okay.
through the nipple, I will pass the nephroscope. Even 18, some of the torn nipples I keep, which will be used for passing 18 French amplage sheet, 19 French, sorry, nephroscope. So I will put the nipple so that the fluid does not come out. And then when you pass the nephroscope, the whole system distends well. And then you can easily go from one calyx, the infundibulum also widens up. The pressure inside the system might increase for some time. If it is taking more time, then more than 5 or 10 seconds every time, then in between I'll just open up the nipple, drain out the fluid, then put the nipple back with my left hand. And with the right hand, I will be putting the nephroscope through the nipple. So the whole system distends up to its maximum. But sometimes the upper calyceal infundibulum is at a very more than 90-degree angle, very acute angle. It is tortuous and you cannot enter there. Then definitely, if the stone fragment has gone from pelvis to that, then it will come back also. So
Yeah.
in that case, I will make just a puncture in that calyx and flush very hard. So this stone, which I no need to go to the stone will come back.
Yes, sir.
But if it is a stone which is already there, even then I will try flushing. And by flushing, if it does not come out, then I may make only a 12 French track. Through the Elkin cannula, I will pass 8 French nephroscope, see the stone. If just because of some anatomical obstruction of the
Yeah.
infundibulum, it is not coming
Yeah.
out, under vision, I will, with the nephroscope, I will give a tilt or push to it and try to bring out into the main. So
Main.
only 12 French will be enough. But if everything doesn't work, then I will increase from 12 to 14 or 16 and use a 12 French nephroscope and make additional track and repeat. So all
Okay.
these gimmicks I try on table.
Yes. So my seventh question, last three questions. Some people say that mini per middle calyx is the answer for all prone PCNLs. One of my teacher, one of your close friend from Nepal says that mini per and but not 12 French. He doesn't say 12 French. Mini per middle calyx is the answer. Does tract has anything to do in prone PCNL, honestly? Or it should be everything case based, everything on the RGP, everything on your intellect on analyzing the stone in relation to all the calyces. Other people say, some countries say that, yes, it's isocentric calyx, mini per with middle calyx is the answer for all prone PCNLs. 99%. What is your comment on the size of the tract and the choosing only middle calyx?
No, lot depends upon the anatomy of the kidney, because at times there is a middle calyx has an acute angle to the lower calyx and to the upper calyx. I will not try to torque the kidney or to mobilize it excessively. Even if you don't tear inside and try to mobilize, hang it on your like a, something and mobilize it too much, there are chances of perinephric hematomas. So I respect kidneys. I will see the angulations. Then I will see whether the middle calyx will lead me to all the calyces. And as you have mentioned, the gentleman Sanjay, when he goes through the posterior calyx, middle anterior cannot be entered because
Yeah,
they are parallel to each other, and you will have to make a Y track into that. So middle anterior is not there, and at times the inferior calyx is so much angulated that entering in that will give a torque at the interpelvic area, in that opening area of that, where there is again chances of vessels being there. So I will not agree with him 100%, but yes, for the pelvic stone, for the upper ureteric stones, this middle posterior is good, but not always.
not always.
Selectively, on the X-ray, always make a straight line and see that straight line, because all our nephroscope are stainless steel stone, hard nephroscopes. They will move only in one straight direction, maybe 30° here and 30° there. So on the stone bulk, make a straight line, then see which axis and corresponding to which particular calyx and infundibulum. From there you make an entry and remove the main bulk and remove the main obstructing bulk, means stone which is at the PUJ must be removed in your first session.
Yeah.
You are not, maybe second session may not be possible because of some complication, something happens. But in the first instance itself, in the first session, the PUJ stone must be removed so that the pelvis starts draining downward. So all
Yes.
these points you have to consider, then choose the calyx of your choice.
Yes, sir. Important question again from the audience. Ali Men, does body habitus matter in selection of tract size? Okay, some logic, not
Yes, particularly if your stone bulk is orienting and asking you to come through the lower calyceal medial calyx, lower calyceal medial calyx.
lower calyx,
The
medium.
patient is female with big buttocks,
Yeah.
then it becomes very difficult.
Yes, sir.
So in that case, you have to position the patient on the your kidney bridge. The kidney should be on the kidney bridge
So
so
that it's
that in
bridged.
between you can flex it both the sides
Okay.
so that the buttocks will go down,
Okay. Okay.
and
Okay.
only then you will be able to enter inside.
Yeah.
So
That's
this point you have to see for the body habitus
yeah. That's
particularly, and regarding
in
the
supine
superior
PCL, it is impossible to puncture that stone, sir. Impossible. Even prone, you are saying that buttocks will come. This is a very good point, which I never thought. Is it all the tables can do that, or you need only something like heavy pillows can be put under the But obese patient, that also will not rise. Table has to be broken. Table has to be broken.
Yeah, table has to be, because you cannot chop
You
up the
cannot
buttocks. No, you have to only break
only
the table in
break
between.
the table and down the buttocks.
When there is a buttocks will go down, then your entry will become easy.
Space will come for you.
So in a female with big buttocks and lower calyceal stone, just see that where your entry is and what is. Otherwise, come from the superior calyx.
Last two
Then
questions. Wasim Ashraf again asked, irrigation pump simply in the irrigation bottle with discarded pump of sphygmomanometer help in improving vision in miniper, which is a problem with despite being advantageous. Ultimately, is asking pressure raised with nephroscope itself to do the procedure better with miniper. Doing wrong thing with covering up with pressure, something correct or not? PCNL is known for low pressure.
if there is a staghorn which are usually associated with infection, or if there is a turbidity, then I will not cause any rise of intrapelvic pressure. Never I will try to use this high irrigation. But otherwise, short lasting, maybe 5 seconds or 7 seconds to have a good visualization inside, putting the nipple and going in, distending, then immediately opening up the this nipple and draining the fluid, then going in, then it doesn't matter. 5 to 7 seconds or maybe 10 seconds rise of intrapelvic pressure are short lasting. Say they may not cause septic complications to that extent.
Yes.
You should be aware.
Aware.
Not constantly you should increase the intrapelvic pressure. But at the same time, good vision and good clearance is also of paramount importance.
Yes, sir. Sir, last question, sir. I will add ABCD in this so that question will finish. I can't leave you so easily. Comment on 4 things, sir. If you wanted to have a second definitive puncture needed in your mind, how facing you have technique of flushing, that is your favorite. Sometimes I tried, but it comes and goes, so I dilate and remove. In that case, what size dilator? Whenever small stone is there, how do you assess what size should go? 12 French or again go back like that? Second question is angulation of the nephroscope. Which angulation is good? 5, 10 degree or 0 degree? Third is any comment on the long nephroscope in your experience? When will you use the long nephroscope? Normal long nephroscope, when will you use? And any comment on flexible nephroscopy? Because no conferences I have seen prone PCNL surgeons using flexible nephroscope and struggling with laser or forceps or this thing. They simply go for another puncture and remove it. I attended many conferences, many doesn't use. So 4 questions I asked. Second tract, what is your comment? Degree of the nephroscope, length of the nephroscope, and flexible nephroscope. This is the last questions.
First thing is minimum intervention. So just needle and flush. Needle flush, if it doesn't work 5-7 times, you have pushed 20 ml saline and the stone is not coming, then I will put the guide wire and have a nephroscopy again from the main track. Sometimes identification of that particular guide wire is coming out into the system. So you just follow the guide wire back. At times you are able to, if the infundibulum is not very long, the calyx is very short stub, then you are able to go in this direction in the. Am I able to explain properly?
Yes, of course, I understand.
So just follow the guide wire from inside to outside, and if there is not much of angulation, just by this you will be able to remove. If these 2 measures fail, then I will pass the Elkin cannula over there. Elkin cannula and then remove the guide wire, because with the guide wire inside the Elkin cannula, no nephroscope will go in.
Yes, sir.
If you don't have a 8 French nephroscope, use your 6.5 French ureteroscope.
Yeah.
And have a vision of the stone. And with the beak of the stone, at times you are able to lift up if the stone was getting lodged in somewhere which was not allowing it to move up and jump into the renal pelvis. Then maybe with the help of your nephroscope and under vision, you will be able to push it inside the system. If it is slightly larger, then with the ureteroscope itself, make into smaller pieces. Some pieces you will remove from there, some pieces you will push back into the renal pelvis.
Yeah. Yeah.
All this while, my full attempt is to push this stone into the main system
Main
from
system.
where I can easily pick up stone or stone.
Intact. Intact.
If all these three fail, then only after 12 French, then I will pass the guide rod and make the size to 14, 16 or maximum 18.
Remove
The
it into
secondary tract is never beyond 18. And with the 12 French nephroscope, most of the stone bulk can be removed.
10.
So this is the first
A
part.
part of the
Go
question.
step by step. Only needle puncture, Elkin cannula, ureteroscope, and try to
Correct.
bring to the vein.
Further.
The second part
Angulation of the scope. Angulation. 5 degree, 0 degree, 10 degree.
doesn't make any difference. You get used to whatever you have bought, but not more than 12 French, 12 degrees.
12 degrees.
Yeah, 30 degrees becomes too much angulation.
Yeah. Yeah.
Usual nephroscopes are either 0 degree, 5 degree, 6 degree, and 12 degrees.
Sir,
So anything is good enough. You get used to it. Doesn't make any difference whatsoever.
you have what length extra scope with you? Sometimes extra length may be required.
Yeah, that is only for the all my
Partial.
staff knows whenever there is a anomalous kidney, unascended
Partial.
kidney,
Yes, sir.
horseshoe kidney, then I
Obesity.
will always keep a elongated nephroscope ready and a longer implant sheath also I have. So those I'll keep ready for anomalous kidneys. Routine
Yes,
kidneys,
sir.
obese patient doesn't make a difference. Even in
Yes,
a
sir.
very obese patient, I have seen if you go from behind the track of the track length is not much. It is like any other person.
Uh, Unfortunately, one basic question we should not close without all 200 people have joined with your craze. But it's a good question, simple question, but very valuable question. Please accept this question. Sandeep asked, sir, in complete Stagwar, if guidewise is not going into the system, how to proceed, sir? Not related to the tract size, but that's a very tricky question. It's not easy to answer, but he asked, so please explain, sir. We feel the stone, everything we feel, but the guidewire doesn't go.
See, if this is the stone, this
Sir,
is my needle in the center of the stone,
yes,
guide
sir.
wire will not go in.
Yeah,
So what I have to do is I have to keep the needle tip here only. I have to bend the needle hub. Now the direction of the guide wire will be over the back of the stone.
slips.
So I will keep the needle tip here, ask my assistant to increase fluid from below so that the space gets created between the stone and the pelvic ileal system.
Yeah,
The system should be nicely distended. So
yes.
when he is distended with the 20 ml saline syringe from below, I'll put this down, the needle hub will go down and then try to glide either a Terumo guide wire or a zebra guide wire. My
Yeah,
J-tip will not go at times and it will slip over. At times, nothing works. Nothing works, even depending and all this, it is going, but it will, when you are pushing again and again, you will make some false track here or there. You
yeah,
know that guide wire is going out.
yeah.
Be very sure that you were touching the stone and you had got some fluid. After that, push your guide wire, let it go anywhere outside the system.
Anywhere.
Doesn't make any difference. Make your Elkin cannula up to the or 12 French track right up to the stone lateral border of the stone. Then pass
Yeah.
a
Yeah.
ureteroscope
Yes,
or
sir.
a 8 French nephroscope, see inside under vision, then try to find here, there, somewhere from where it is going into the pelvic ileal system. Pass a guide wire, then increase the size of your track and go ahead. So
Thank
don't lose heart if the guide wire doesn't go. Try these maneuvers or let it go anywhere, let it get coiled anywhere, and then make a track only up to this one,
you. Yes.
only up to this one, smallest possible track. Then under vision proceed.
Great, sir. Very nice explanation. Very nice. One kidney bridge and this last part are two my learning points. And of course, 200 people watching means it's a great thing. I wish all the audience, please spread this thing. So many points in 2 days we can learn at a very, very low cost. That's what particularly I'm proud in India in such a way that teachers are totally dedicated from their heart. So let us meet all of us in Parkan with Dr. S.K. Palsar. You have seen how much heart he has put into each answer, especially the last answer. I am really impressed. Thank you very much, sir. I am really impressed. Thank you very much. And my sir, in movies and in TVs, the PR rate, what is that rate will be QR rate by one movie. If you put the rate will TRP rate will increase in a month once. A good surgeon and good teacher like you increases the pure urology TPR rate, and lot of people will join tomorrow from Egypt, from Morocco. Everybody will join tomorrow or another. Now it is 11,000, sir. You have shown 9,600. It is 11,000.
Right.
Yeah, thank you very much, sir. You add for the value of the pure urology, and it's a great pleasure.
Unfortunately, I could not get the teaching opportunity or a teaching job.
Yes, but you are doing more.
But
You are doing more
the
than that.
passion,
And you
so
should watch your first case in Perkan always. Every minor detail, because you told 75% of the juniors, the first year of urologists, with the senior most thing that I am seeing this second time or third time, but the first year will be seeing the first time, which he has never seen a puncture in his institute or in his college. So he will be very, very happy. That is the aim of ultimately aim. As long as we can do, and you are doing it that position, small pads, that the first half an hour cannot be missed. Cannot be missed. Really. See, let it be simple case, it doesn't matter, but what is anterior, what is posterior, 30 degree, 0 degree. You explained so well. Let's wish it will be again one more academic bonanza, sir. Thank you very much, sir.
thank you, Chandra. Thanks
Thank
to
you.
the audience. Thank you.